In this series of videos, we've been looking at clinicians' nightmares. We looked at whiplash last time through, and this time we're going to look at tennis elbow. Tennis elbow is one of those conditions which describes pain on the outer side of the elbow, as opposed to golfer's elbow, which is pain on the inner side of the elbow. And it's one of those conditions that can be notoriously chronic and very hard to predict the time course. Now, essentially, a tennis elbow in its true form refers to a tendonitis of the insertion of the forearm muscles on the outer bony edge of the elbow. So the muscles at the back of your forearm that extend your fingers and your wrist, the fleshy part of the muscle is located through the forearm, and then there's a tendon attachment onto the bony edge on the outer edge of the elbow. And this is the area, if the tendon becomes irritated, that you find quite specific sharp pain, usually related to gripping activities or activities such as pouring a kettle. That's a classic one because you have to work those muscles and you put tension through the area. So they're usually the kind of factors that cause aggravation. Sometimes they're a gradual onset with no really clear-cut mechanism of provocation, and other times there's a specific history. A classic one is gardening in spring, using a secateurs where there's a lot of gripping action, sometimes prolonged carrying, turning screwdrivers for DIY at home is another classic one. And ironic as it sounds, the vast majority of tennis elbows don't happen from playing tennis, although grip does definitely seem to be a component. And you'll see it in athletic folks who train a lot, particularly things where they're doing a lot of grip and hanging work, where there's a grip element and an involvement of elbow bending and straightening, which causes some friction on the outer edge of the elbow. Now, the pain in the forearm can come from the actual tendon on the outer edge, or it can come down from the musculature. And if people present with symptoms in the forearm muscles, that's usually a better prognostic sign, because the muscle is usually has a much bigger blood supply and a much better recovery rate. So we can usually be fairly confident that should be a short-lived episode. But when the irritation is actually very focal and very specific, and people get acute soreness on the outer edge of the elbow, that's a much harder thing to predict. So in reality, there are a number of things we look at. One is how inflamed and irritated it is, and it's usually not inflamed to see, so you don't see swelling as such. It's just exquisitely sort of touch. But if it's very angry, as we would say, if people find that if they do something that grips, it could leave it sore for many minutes or an hour or two afterwards. So you know it's a very, very angry, irritated tissue. So you have to be careful with how much you try to do with that. And oftentimes your primary objective is to take the pressure off it and unload it when it's that angry. If it's just acutely sore to grip, shaking hands is another classic one, and it makes you always release the grip, but then the pain goes away immediately. Then we know, although it's painful, it's not very irritable and sensitive, so you can tend to try to get through a little bit more work. But the reality is that the physical signs of an examination don't give you enough clues to predict whether this is going to be a simple tennis elbow that can resolve in 2 or 3 weeks, or is it going to morph or evolve into one of those chronic tennis elbows that can go on for months and months, and then a proportion of those just never settle down. Now, obviously, there are other factors that feed into that in terms of how people use their arms every day. So people who do a lot of grip work using power tools or holding objects, plasters, brickies, those kind of occupations where there's sustained continuous load on the forearm, that can be a real problem when it causes aggravation, because it's generally not an option to rest it. It usually happens in the dominant arm, so again, it's not practical to just put the arm in a sling. Nobody does that as a form of treatment. So from a physiotherapy point of view, what you're often end up doing is using certain kinds of taping to try and unload the sensitive area, using various kinds of modalities, whether that's electrotherapy devices, manual therapy, or dry needling to try and take the sensitivity out of the area and stimulate repair and recovery. And then it comes down to starting to put some progressive load on the area, but trying to stay just short of the point of irritating it. And usually grip is a good measure, pain-free grip in different angles. Sometimes you can have a nice comfortable grip with a bent elbow position, but then when the arm is out straight, it's a more exquisitely sore. And that really just comes down to what combinations of angles put pressure on the tendon. Now, that's, if you like, the scenario for your true localized tennis elbow, but very often tennis elbow is multifactorial, and there are contributions from the neck, from the shoulder, from the nerve tissues that run down through the arm and pass across the elbow. So very often, particularly if there's a gradual onset, we need to look and examine for signs of abnormality in these other tissues. People may not necessarily be sore or be aware of any problems in those areas, but when you examine them, you can usually elicit positive clinical signs there. And it's always important to target those if you find them in a tennis elbow. Otherwise, you can just treat the problem in the elbow and hope it goes away. But if you don't see those improvements happening over 2 or 3 sessions, then you know you have to actually look a bit wider. So it does mean that the clinician has to be vigilant and have to look for all of the contributing factors that can potentially turn it into a chronic problem, because a chronic tennis elbow is a real problem. Everything gets thrown at it, from cortisone injections, from what are called epicondylar clasps, which are braces, which can be effective for some folks, particularly if their pain is on a grip-related sports activity. So that can be a help. The jury's out on the effectiveness long-term of corticosteroid injections. Can give temporary ease, but evidence would suggest that it can make it more likely to recur and be more persistent down the track. There used to be more of a trend for surgery to actually remove the tendon attachment where it's sore, but I haven't seen a surgical approach for a chronic tennis elbow for many years now, and that's generally because the outcome is very unpredictable, so surgeons aren't too enthused about offering that as a solution. So from a clinician's point of view, when we see someone on a Monday who's just come in from a heavy weekend of gardening and they tell you they've got elbow pain, we look for all of these contributing factors. We look to try to identify what the main structure is that's sore, and then we try to treat it in a most effective way. And we need to see really over 2 or 3 treatments that things are improving and moving the right way. Sometimes it doesn't go in a nice steady upward trajectory. Sometimes it's a slower recovery. Sometimes it's undulating, so it's good and bad, and it varies. And sometimes nothing changes at all. So again, you have to be vigilant and observe, and if things aren't changing, you need to question, are you missing anything, or have we just got a case here of a condition that's going to be very angry and long-term and hard to resolve. So lots of different things go on with a tennis elbow. There's usually nothing to see. You don't see swelling or deformity or anything like that, so it doesn't look particularly dramatic, but it can be exquisitely sore. And obviously for social situations, shaking hands, if that's a situation you're in frequently, people will often wince, which is why you're not allowed to shake the Pope's hand or the Queen's hand very vigorously in case you trigger a tennis elbow. So just thought I'd give you a little bit of background on another problem that can be a simple issue or turn into a chronic issue, and clinicians are always aware of that potential. I'll see you again in another video. Bye for now.